So it's a great pleasure for me now to introduce our second speaker, and this is Professor Lisa Filipovich from Cincinnati. And just some notes about Lisa. So Lisa began her career at the University of Minnesota, where she received her medical degree and then completed fellowship in both immunopathology and pediatric immunology. She became a professor of pediatrics and served for 10 years as the head of the division of immunology at the University of Minnesota Medical School. She then moved on to Cincinnati Children's Hospital, and she is currently the chair of clinical immunology and the director of the immune deficiency and histiocytosis program. She has served as a medical director of the Diagnostic Immunological Laboratory at Cincinnati Children, and Lisa is known to all of us for her huge experience in bone marrow transplantation, also, of course, in Wiskott, and would like to hear your talk. Thank you very much, Lisa.
Thank you very much to those responsible for the invitation and to Dr. Etzioni for the kind introduction. So we're going to shift to a different territory, which is the clinical work. And I'm going to touch not only on the history of treatment of Wiskott-Aldrich syndrome and where we've come with transplantation of bone marrow, or what we call hematopoietic cell transplants, and very briefly about gene therapy. I know Adrian will have more comments about that later. So this is the program. And much of the talk will focus on what little we know about predictors of success with hematopoietic cell transplantation in the current era. And I'm going to end with a family journey through transplantation, what is actually involved. I'm told that there are a few family members here, and the progress toward providing rational and safe therapy to affected children is by necessity a partnership. It has to be a partnership among not only the medical community but also the family and its supportive community. So this is not the photograph that you see in most articles about Wiskott-Aldrich syndrome, although it looks exactly the same. This is actually a patient I treated from the original Aldrich kindred, and you've already heard about the variety of very significant complications that arise in this disease. I'm going to give you just a little bit of history, at least the known history. And this is Dr. Wiskott. This is a photograph that I got from Hans Ochs, who got it from Dr. Belorodsky. And this physician in Munich in 1937 was studying a family that obviously had a hereditary disorder. And you see on the lower panel that in this family there were many children. There were 5 daughters and 3 sons, all of whom were affected with what ultimately came to be called Wiskott-Aldrich syndrome. And in a brave move, he actually published the family with 2 of the affected members. Of course, this was the run-up to a very sad time in Germany and in Europe. But it was very, very important to the science of the disease, to the medicine of the disease, I should say. And this is difficult to read. In fact, I had to go to the Google Translation Service to find out what all of this said. But here we have the charts, the trajectory of these 3 boys. And their ages are listed here. And you can see some of the problems that they had. Eczema, colitis, they all had colitis, edema, infections, and these little dotted lines, I believe, are blood in the stool. So that was an ongoing problem at least in two of the boys. So a very classic description of the consequences of this condition. Back in the day, my colleagues at the University of Minnesota were funded to undertake a clinical review of Wiskott-Aldrich syndrome from 1892 to 1979. So they poured through charts that were thought perhaps to have this disease, the few case reports, and what was available on death certificates, and collected 301 cases of likely Wiskott-Aldrich syndrome in the United States and Canada. And the purpose of this was to identify the proportions of patients who developed the various complications, their survival, and other outcomes. And here is a critical figure from that study, which shows survival over periods of time back before definitive therapy was available. And here we see the survival in patients who were born between 1892 and 1934, with a median survival of certainly less than a year, something close to 6 to 8 months. And here in these other curves, we can see the survival in patients who were born in the most recent era that was studied, 1965 to 1978. And at that point, the median survival was 8 years. So still not very good. And this is really the point in time when physicians began to test whether bone marrow transplantation and ultimately gene therapy would have a significant impact on the disease. And of course, we all anticipate and know what the results were, but there's still a lot of work to be done. The Aldrich kindred, which was located in North America, was described in 1954. And Dr. Aldrich reviewed 6 maternally related generations of individuals who had the constellation of symptoms that he was looking for, and discovered that 16 of the 40 males in the family were affected and no females. The leading cause of death among these individuals was, of course, infections, followed by hemorrhage, and an incidence of lymphomas of greater than 20%, some occurring after 20 years of age. Cases from the Aldrich syndrome, Aldrich kindred, continue to be seen in the central United States. In fact, we've seen 4 patients at Cincinnati Children's over the last 5 years. None of them know each other. We took a little sleuthing to sort this out. And I think, importantly, the clinical presentation in this family has ranged from XLT to the full spectrum of Wiskott-Aldrich syndrome. Clearly, they carry the same mutation in the WASP gene, but there are other features that predispose to or contribute to the clinical expression. And just one more comment about the lymphomas, and this is work I was involved with in the federally funded immunodeficiency cancer registry, and the findings included that the highest proportion of patients with lymphomas among a variety of primary immune deficiencies that were studied were found in those cases of Wiskott-Aldrich syndrome. The mean age in the study was about 7.6 years, but ranged up to 22 years. As has already been stated, predominantly B-cell in origin. To this day, we understand very little about the pathogenesis. The central nervous system is the predominant site, and the age-adjusted incidence is estimated at greater than 360-fold above the general age-matched population. And I think you're going to talk about this later, so I'll go on. And moving on to treatment, the first case of bone marrow transplantation in a patient with Wiskott-Aldrich syndrome was published in 1968. This was a 2-year-old boy who experienced many pneumonias and had already had 2 cerebral hemorrhages. His first transplant was from a sister who was MLC non-reactive. It was a bone marrow infusion, which resulted in no engraftment. Subsequently, a second transplant from the same donor was given following Cytoxin preparation, and that resulted in partial engraftment. So there was take among the T cells, but not the entire T cell population, and the patient remained profoundly thrombocytopenic. Some years later, when he was about 19, the patient underwent a third bone marrow transplant, and this time he had full myeloablative conditioning with busulfan and Cytoxan. Same donor was used. He was at this point what we would consider for the disease at an advanced age for transplantation, and suffered the rest of his life with acute then chronic graft-versus-host disease and ultimately liver failure. And he died at age 36. But a very important advance. So considerations for use of transplantation in Wiskott-Aldrich syndrome, and this has already been nicely defined by Dr. Thrasher. It makes sense because all the primary cellular defects originate in bone marrow-derived cells. But time moves on, and in the present era, we do not know, cannot really predict what the natural history and life expectancy without bone marrow transplant or gene therapy is in the current era with the advancements that have occurred in the medical field. Another consideration is that physicians and families don't always feel the same way about having a transplant, let alone about how successful the transplant was. So the assessment of transplant outcomes between these two important partners may be quite different. The first large study looking at outcome of transplantation for Wiskott-Aldrich syndrome was published through the International Bone Marrow Transplant Registry and covered the period of 1990 to 2000. This showed that there were significant differences in survival based on the donor that was available for the transplant. And what was particularly encouraging was that the results with the HLA identical siblings at this point, at that era, were really quite good in the range of 90% long-term survival. And furthermore, if a patient was treated at a relatively young age, less than 5 years of age, with an unrelated donor, they had an equivalent survival. I think this really opened the door for more use of closely matched unrelated donors, not only for Wiskott-Aldrich syndrome, but for many other diseases and other primary immune deficiencies. Another finding was that if the transplant was delayed until the patient was greater than 5 years old, which translates to more morbidity, and the unrelated donor was available, the outcomes were significantly inferior. Importantly, the clinical status of the patients was also analyzed in this study, and it showed that regardless of the donor type, a very high proportion of patients described themselves and met criteria for scores of being cured or significantly improved. And a few patients were not in such good situation. So not only are they surviving, but they self-report as having a good quality of life. A few years later, when more cord blood transplants had been performed, a second analysis was done looking at the outcomes with unrelated bone marrow or unrelated cord blood in patients under 5 years of age. And you can see that they are essentially equivalent. There's been a lot of buzz about autoimmune cytopenias following transplant for Wiskott-Aldrich syndrome. And I suspect a little bit of clarity is coming into that question, because it's a troublesome complication or residual to deal with after a transplant. In 2007, collaborators from a number of European centers agreed to report information using a strategy of retrospective questionnaire survey investigating a number of late post-transplant outcomes. 96 patients with 2 or more years follow-up were collected, and among those, it was found that 20% were living with autoimmunity, a variety of types, but mostly autoimmune cytopenias, and in some cases many years beyond the actual transplant. They reported that this was not associated with chronic graft versus host disease as once suspected, but appeared to be significantly associated with persistent mixed chimerism. Other late effects that emerged from this study were a very good result. 70% of patients reported an excellent quality of life, but there were also late deaths from infection in splenectomized patients, and not too surprisingly, late neurologic sequelae, often related to pre-transplant intracranial hemorrhage. Moving now toward the more recently published outcomes of transplantation, within the last year, there have been 2 new series, completely different sets of patients. One published in Blood in 2011 was a multi-institutional, international, obviously, survey of 194 patients treated over a 30-year period. The second, following in 2012, was our own experience, 47 patients over a 20-year period at Cincinnati. There were some important similarities in the reported outcomes. In both studies, most patients had received what's considered a myeloablative conditioning protocol. I think that's important to remember. And even with that, about a 10% rejection rate was found. Also, importantly, in both studies, more unrelated donors were being used, and survival has improved since 2000 to an equivalent extent. Here's the survival data for the multi-institutional study, which indicates that if the child was treated basically under 5 years of age, a very excellent survival was experienced, and here again we're talking about unrelated donor transplants, whereas older patients did not do so well. So the same theme as we've seen before, but substantial improvement as to where this curve ends. I'll show you a little more detail about our Cincinnati experience because I have the data. So again, 47 patients. A number of aspects were investigated, including acute and chronic GVH, platelet recovery, immune recovery, autoimmunity, and quality of life. And it was useful, we found, to actually divide patients by transplant era. So here we see the most recent patients, a larger number of patients, median age quite similar. You will notice that almost all of the patients who had unrelated donors in both eras. So this is really a study of the availability of donors today and the choice that BMT physicians are making. Pre-transplant characteristics showed the usual complications that these patients have. Essentially all had microthrombocytopenia. They showed a variety of immunologic abnormalities, including decreased CD8 T cells and immunoglobulin problems. And here's the overall survival. So the upper line shows the survival post-transplant in the most recent decade compared to the previous 10 years. And here it's broken down according to age at transplant, showing that in the current era, we have this magical result of 100% survival in patients less than 2 years of age. Now, obviously, it's never going to be 100%, but this is a significantly different result. And the most important segregating factor in multivariate analysis was actually the transplant era, suggesting that the variety of little improvements that we may be making or learning over the years contributes to better outcome. And lower age at transplant is a close second. There weren't many deaths, but you can see here that those most common were due to sepsis. And here we see acute graft-versus-host disease, basically showing that this is grades 2 to 4. Let's just concentrate on this, that there was no difference in the definable mismatch of this predominantly unrelated donor transplant experience. And by transplant era, there is a significant difference in a much lower incidence of severe acute graft-versus-host disease in more recent years. Platelet recovery in all patients, platelet count greater than 100,000. Here we see a variety of immunologic features. Importantly, normalization here of CD8 counts is what this reflects, and significant improvement in natural killer cell function at the latest time point. Well, back to a common theme of the autoimmune cytopenias. This is a list of the distribution of the 17 patients out of 31 patients where data was available. indicating a 55% incidence of post-transplant autoimmune cytopenias, and some of them were multiple cytopenias. This table shows in more detail these 17 patients. An important finding was that almost all of these autoimmune cytopenias were diagnosed prior to 6 months post-transplant. At that point, virtually all the patients, with 2 exceptions, were fully donor chimeric and continued to be until the time of last follow-up. There was no clear association with chronic GVH, which was seen in only three of the patients. I'll get back to that in a minute. The performance score was good. Anything greater than 80% is considered within the normal range. And so that is sort of a look at a defined experience of transplantation, examining various of the important outcome features. I'm going to segue just for a minute to the results with gene therapy. I think Dr. Thrasher will speak more to this in his second talk. But as we all know, in 2010, there was the first report in the New England Journal of Medicine of gene therapy for Wiskott-Aldrich syndrome. They happened to be 2 3-year-old boys. This was a strategy of introducing the vector into CD34 positive stem cells with prior treatment of busulfan for 2 days. And the publication appeared 3 years after gene therapy, up to which point no adverse events had occurred. And the data looked very encouraging. Here we see the recovery of the T-cell subsets in subject 1, maybe a little more delayed in subject 2. We're looking at 24 months here. Myeloid recovery, not quite so good. Platelet recovery, very encouraging, achieving a normal platelet count of about 150,000 at 1 year in the first patient, and a somewhat lower but a safe platelet count of around 60,000 in the first year. And this led to much joy until the day of publication, when the Hanover team announced that a patient had developed T-cell ALL. And subsequently, I'm told either 3 or 4 other boys from that cohort have developed T-cell ALL. And this is associated with the vector homing in on those sites, that the common sites that are seen in other cases of leukemia following gene therapy. So great elation and then sobering disappointment. But the work goes on. So a few comments about how we manage Wiskott-Aldrich syndrome in the current era. I personally believe that splenectomy should be avoided. We can't be absolute about everything, but I think that every patient deserves a treatment plan. Where are we going? What are going to be the criteria for changing direction? Keep looking for a better solution, and I think it has to be a very active process. I believe that patients with XLT should be considered, and there are many extenuating circumstances. I think that you will speak your mind, Adrian, about that. because the data indicates that survival and quality of life, with good quality of life, is improved if transplant is performed at a younger age. That appears preferable, but we do need to monitor growth and thyroid function in children during these active years of development. There are many unanswered questions. One of them that always comes up is fertility after myeloablative conditioning. And I actually received a gift about a month ago in the form of an email that I think is going to open the door to finding the answer to this. So the email starts, Dear Dr. Filipovich, this is Subir. And I immediately remembered him as a 2.5-year-old child standing up whenever he had something to say. This is Subir, I need your attention. And then he went on to say, thank you so much for saving my life, yada, yada, 30 years ago, and I am now happily married, and we have a 2-year-old daughter born in the natural way. So I think I'm going to try to engage Subir with his Facebook friends to get a little more information about this topic, because we really don't know. These patients get lost, and we make assumptions, and I think what we need is real data. And of course, we'd like to use less chemotherapy, less cytotoxic agents, not only to preserve fertility, but also the immediate, to decrease the immediate side effects. So we have to work on a less toxic conditioning regimen. In the current era, there are still a number of factors that conspire to affect the outcome in these patients. One of them is a primary immunodeficiency genotype. We already talked about why Wiskott-Aldrich syndrome is favorable. The clinical status of the patient and age at transplant is a rough correlate of that. Transplant center experience, my personal opinion. Conditioning, very important issue. And then there are a number of intangibles. The patient's psychological constitution, the family makeup, many factors that play into a successful outcome. However, in the current era, donor match is not that critical. Cord blood is a viable option, and I think most patients have at least the opportunity to consider transplantation. And of course, we hope that gene therapy will supplant that in my lifetime. And I think I'm just going to end by commenting on the donor chimerism issue. My suspicion is that autoimmunity post-transplant, particularly the autoimmune cytopenias, may arise or exist for two somewhat different reasons. The experience at our center of post-transplant autoimmunity early, first 6 months post-transplant, with full donor chimerism and resolution actually in all cases, suggests to me that this may be a function of residual plasma cells that continue to generate autoantibodies, as we know, for all antibodies for many months, and then they just burn out. A testable hypothesis, not necessarily in people, but perhaps in other species. Whereas the persistent mixed chimerism in the series that was published from the EBMT, in the context of, many years later, suggests that WASP-negative cells are continuing to permit and create the autoimmunity, and making an argument for trying to establish a very high level of a WASP normal chimerism in the B and the T cells. And it's now very easy to measure. This happens to be a flow cytometry plot showing, in this case, the control, different immune cell types, and here is the progression over time, 6 months and 13 months, toward more complete donor chimerism in the different cell lineages. So this is a technology that is readily available and can help us understand how to manipulate the system and where things are going. So what is cure from Wiskott-Aldrich syndrome? Well, it's freedom from all these things that are on this list. And then finally, I was just going to speak very briefly about the trajectory of how transplant works for Wiskott-Aldrich syndrome. And the important thing is that there are many different steps along the way. They have to proceed in a reasonable schedule. You can see that even after the conditioning occurs, there are many critical phases to a full and successful recovery. So you have to traverse the early neutropenic phase, then the early weeks of discharge from the hospital, which are very complex in many cases, then the discharge home, which is not to the normalcy of home, but it is hopefully at home, return to normal. School, for example, cannot be expected until 1 to 2 years post-transplant. And at that time, the patients may still be on a variety of treatment, particularly immunoglobulin replacement and antibiotics, and cannot be safely re-immunized perhaps until several years later. So it's a long journey. And with that, I thank you for your patience. And